I'm ready if you're ready.
McMurray's test.
McMurray's test. Patient is supine, arms at their side, completely relaxed, heels on the table. Give me another couple minutes. All right, I'm gonna explain this first because this is for a meniscal tear, but we don't know where the tear is. So we have to apply a lot of compressive forces to the meniscus in hopes that we can somehow catch that little flap and make it click. So ultimately what I'm going to be taking him through is a combination of knee flexion and extension, valgus and varus, as well as tibial internal rotation and tibial external rotation. So I'm going to demonstrate it first with each individual motion. So, clinician off to the side, I've got the medial malleolus. I have my thenar eminence on the head of the fibula. I'm going to internally rotate the tibia. I'm going to provide a valgus force, and then you relax. I'm not going to hurt you. I'm going to bring him up into flexion and then extension. Then I'm going to provide an external rotatory force to the tibia. I'm still doing my valgus. You got to relax. Okay, and I'm bringing him up into flexion and extension. Now what I'm going to do, I'm going to swing around here, sorry camera, is that I'm going to do internal rotation of the tibia, varus force, and I'm bringing him up into flexion and then back into extension. Last one is going to be external rotation of the tibia, varus force, this is a tough one, and I'm going to bring him up into flexion and extension. So I did all 6 of those passes. I'm going to show you how a lot of our physicians do it. What they will go ahead and do is start you up in a 90-90 position, get their fingers in their joint line, and it's almost like they're just churning butter, trying to move you around into all of those different positions in hopes that they will go ahead and catch the meniscus. So I don't personally care how you want to do it, the first way I did it or the second way, but you must communicate to me that you are doing all of those forces, internal, external, valgus, varus, flexion, and extension. The positive finding must be the click, catch, or pop in the joint line in order for it to be positive for meniscus.
Thessaly's test.
All right, stand up, Edelstone. So you can have feet shoulder width apart. You can be facing me. The McMurray test that we did is frequently called the McDonald's test because it's not very reliable because we're not transmitting the body weight through the joint. So that's why this test is viewed more favorably. Now the meniscus is being compressed by that percentage of your body weight. So we'll say your right leg is affected. What we're gonna do is we're gonna use my arm as an arm bar, so you're gonna hold that. You're gonna stand just on your affected knee. So we'll say your right one, okay? I want you to flex it 5 degrees, and now I want you to go ahead and pivot with your hips, full range of motion 3 times, all the way back and forth as far as you can go. There's 1, there's 2, there's 3. Then I want you to go ahead and do it with your knee flexed closer to 20 degrees. So do the same thing again, 3 times. 1, 2, 3. All right, positive finding here is going to be the catch, click, pop in the joint line for a meniscal lesion. And then as we move you into greater flexion, it increases the probability that it's going to be on the posterior portion of your meniscus. Because as we flex, we compress in the back. If you have the pain closer to extension, remember we're compressing in the front. So if you had it at 5 degrees versus 20, I would assume that the lesion is more on the anterior side.
Apley's compression and distraction test.
Okay, you can lie prone, head up there, feet down here. All right, I'm gonna go ahead and passively flex his knee to 90 degrees. If I am doing this for a meniscal lesion, what I am going to do is I'm going to provide an axial loading force down into his knee, so I'm compressing the meniscus, and then I'm gonna internally and externally rotate the tibia. A positive finding for a meniscus is pain inside the joint line that, with compression, that is relieved when I'm doing the same thing with distraction. So that is the compression distraction test tied to meniscus. Now, the alternative finding to this is if I have pain when I'm doing distraction, or when I'm having pain with both distraction and compression, it is possible that it could be the collateral or cruciate ligaments, because I'm pulling them apart when I'm doing distraction, and when I'm getting to the endpoint range of motions of internal and external rotation, I'm also generating tension in those ligaments. However, we don't generally use the Apley compression distraction for the ligaments because I have no way of knowing how badly they're damaged or what specific ligament it is.
Wilson's test.
All right, you're seated with your knees off the end of the table. So you're completely relaxed at 90 degrees. What you are going to do is actively internally rotate your tibia. So turn it in, there you go. Now what the patient is going to do is actively extend their knee until they get to the point of pain. So we'll just say you have pain there. And his pain must be emanating from the medial femoral condyle that's over here. So if he gets up, he has pain there, then I'm going to ask him to actively externally rotate the tibia. Now we have opened up the space on the medial side. If he has pain with internal rotation, that is relieved with external rotation. That is indicative of an osteochondral defect on the medial femoral condyle. It's a pretty dumb test.
Noble's test.
Noble's test. We'll do it on this leg here. So you're lying supine. And you're back. All right. So this is a test for IT band friction syndrome. So what I am going to do is come along the side, and I'm going to identify, actually I'm going to get you up in the position first. I'm going to bring you up a little bit closer to like a 90-90 position. That's right here. And then so the camera can see this. Where his IT band is, I am not pressing over his his lateral epicondyle. I am pressing proximal to that. So I'm attempting to take the IT band and press it flat against the shaft. So it has to come or rub around the condyle. So I'm pressing it in there. And now I am passively flexing and extending his knee to ensure that I am clearing the 30 degrees of knee flexion. A positive finding here is that the patient describes pain not at my thumb, but at the lateral epicondyle as the knee is flexing and extending beyond 30 degrees because it's kind of snapping over it or causing friction.
Ober's test.
All right, let's get you lying on your side facing that way. So the leg on the table, the knee can be at 90 degrees, the hip can be at 45, slide it forward, that's fine, just like that. And then come back towards me, I won't let you fall off. There you go, okay? And his hips, if I found his greater trochanter and I drew a line, that line has to go through his greater trochanter on the other side and be completely perpendicular. So there's two different ways that I can test the affected leg. I can do it with the knee flexed, or the modified, it can be extended. I'm just gonna go ahead and do it flexed. So what I then do as he holds that position right there, just like that, okay? Hips are square. What I'm gonna first do is abduct his hip. Then I'm going to extend his hip so it comes behind him. And then what I'm gonna do is slowly let it go. And I'm gonna see how far down it falls. And for him, it's falling to right there. So, this is testing for IT band tightness. This is kind of like your hamstrings are tight. So, how do we know? Well, if it stays up above parallel to the table, it's super tight. You know, if it comes down to parallel to the table, it's moderately. And then if it falls down a little bit at or to the table, then we're talking about mild tightness of the IT band. And you can do it both with the knee extended and the knee flexed.
Q angle with knee extended.
All right, let's just have you lie supine. So for this, all I'm doing is I'm lining up my landmarks. So my stationary arm, even though there's not going to be any movement with this, my stationary arm is going to be his ASIS. Where's it at? Right here. So there's his ASIS. I'm going to, my fulcrum is going to bisect the patella. My movement arm, although it's not moving, is going to go ahead and be the tibial tuberosity. So I'm going to get you just like that. Perfect, just like that. So there. Find my landmark here. This. That's lined up. That's lined up. All right, and then right there. So I'm going to bring this down. And right there. All right, so I pick it up and I look at it, and he's at 10 degrees. So for a male, we're using 13 degrees as the quote-unquote normal, and for a female, we're using 18 degrees. So this is just our static posturing of the Q angle between the hip, knee, and ultimately feet with the tibial tubercle. What do we got next?
Clark sign.
Oh, you're gonna hate this one. I'll do it very easy. He can be supine when we do this. This is for patellofemoral syndrome. And what I am going to do is with the webbing between my thumb and my finger, I'm gonna go ahead and find the superior border of the patella, and I'm pushing with a compression force both posteriorly and inferiorly. So I'm trying to hold his patella down. And what the patient is going to do, don't do it yet, but he's going to go ahead and contract his quadricep. And what it's going to do is take the patella and squeeze it underneath my hand, essentially scraping it all the way through the trochlear groove. Do it lightly. Go ahead and contract. Okay, so he pulled it right up there. Now, the reason I asked him to do it lightly is this should be painful for anybody because you're grinding it there. But if he had suggestions of an OCD, patellofemoral problems, I would expect the symptoms to be exacerbated even more on the affected side compared to the unaffected side. But generally speaking, people don't do this because all it's doing is making an unhappy patient even more unhappy.
Patellar glide test.
Patellar glide test. All right, you will see variations of this, of whether or not you do this in full extension or at the knee at 20 degrees. The advantage of doing it with the knee at 20 degrees is that is the open pack position, so it's better for the joint. The drawback would be it's naturally, anytime we start flexing the knee, we're generating tension on the anterior side. So you can use a bolster and put it underneath. I've seen people use their own knee to kind of elevate it a little bit. I'm gonna go ahead and do this test just with the knee extended. So what I'm doing here is I'm looking at the patella and I'm drawing imaginary lines, so I'm dividing it into 4 quadrants. And then what I want to do is I want to see how many quadrants I can move the patella passively, both in a medial direction and in a lateral direction. So I'm going back and forth here to here. Now the patella should move a little bit. Normal in a medial direction means it's shifting 1 to 2 quadrants. Normal in a lateral direction is 0.5 to 2 quadrants. So whichever way I'm taking it, if it is less than the minimum threshold of normal, that is a positive finding for a hypomobile patella. If the patella were to move greater than the high end of normal in either of those 2 directions, that would be a positive finding for a hypermobile patella, either hypermobile in a medial or lateral direction.
Patellar tilt test.
Yeah, I don't know how people could ever determine this. But what we are saying, again, whether or not you want to use the bolster, a quote-unquote normal patella posture means that the patella is either completely parallel to the rest of the body or slightly tilted 15 degrees facing to the lateral side. So that's kind of normal, that's right there. And then what we're saying is when you go ahead and try to tilt the patella, so I gotta push it medially first, and then I'm trying to lift up and see if I can tilt it even further. When I attempt to do that, how much is the patella moving? Is it moving within that normal 0 to 15, or does it go greater than 15, or it doesn't get to 0? The challenge with this test is it's good to understand the patella should be facing a little bit laterally. But there's no way I can do this and honestly get a gauge of whether or not it's 15 degrees. I just include this because it's in the book and I want you to understand that in addition to a patella glide, you can have a patella tilt as well.
Apprehension test.
Okay. I'll stand on this side to do it. This is for a patella subluxation or dislocation. Not that he has it now, that he has had it in the past. So patient is supine. We're gonna do it with knee extended, but it can be done with knee flexed. And what I'm gonna do, I'm gonna put my thumbs over by the lateral joint line. And with these fingers, what I'm gonna do is I'm gonna try and pull the patella to the lateral side. And a positive finding here is not necessarily how much translation it comes over. A positive finding is that he expresses apprehension because, not of pain, but because he feels as if it's going to dislocate. So that's why we call it an apprehension test. He's apprehensive about it. He feels like it's going to dislocate because the medial retinaculum is torn. There's nothing holding it in. Truthfully, I've got my thumbs here. It's not going to snap over. But if it did snap over, that'd certainly be a positive test for subluxation or dislocation. So that's the apprehension test.
Fairbanks test.
All right, Fairbanks test is essentially an apprehension test. But we do have to begin with the knee flexed here. So it should be flexed 20 degrees. That's not 20 degrees. Pick your elbow up too. I'm gonna do it like this. Now put it down. All right, that's closer to 20. So on this one, what we are doing, remember how I mentioned once the knee is flexed, it produces tension in here. So I'm again going to do an apprehension test where I'm bringing it out, but chances are I'm not going to be able to bring it as far because of the tension. So once I try to translate it laterally, now what I'm going to do is passively extend his knee to bring it, to loosen the tension that's in here. And what would happen is, as the knee is moving from the flexion to extension, the patella is going to glide over a little bit more, and he's going to express even more sensation or apprehension as if it's going to dislocate.
Sweep test.
Oh, my favorite test in the world. I'm not joking about that. You guys should be doing this as the first test every single time you have a patient because it yields so much information. So sweep test, he's supine, arms at his side, completely relaxed. I'm gonna go ahead, I'm doing my sweep test. Love the sweep test. All right, you're gonna milk all the fluid so it gets into the middle of the joint capsule. Then what you're going to do is you're gonna look for the medial joint line and the lateral joint line. I used to do this whole thing where you would karate chop it so you would be right in the correct location, like da-da! I don't know why I do that, but that's a way to get people to remember to make sure you're on the joint line. Very important part of my sweep test.
Of course.
Okay, so then what I'm doing with my fingers along the side, I'm first gonna go ahead and milk all of the fluid over to the lateral side, including pushing the patella. Then I'm gonna start with my pinky here and I'm gonna milk it all the way back to the medial side. And if you do it correctly, you should see a small little pocket that's right there. This is what I'm looking at. So this is a test for intra-articular effusion, so swelling. I am trying to look for the following things. Number one, I'm looking for the volume of swelling that's coming across. Number two, I'm looking for the viscosity of the swelling. Is it thick like molasses? That means blood. If it's light and watery, that's synovial fluid. Third thing I'm looking for is how much time has elapsed between when I'm doing this test and when they were injured. In between these three pieces of evidence, you can help dial in or triangulate what structure may be injured. Just remember, this test only tests structures that are within the joint capsule.
Ballotable patella.
Palatable patella. So what you should do is think about being in the bathtub with your rubber ducky. And so that's what we're trying to do here. Let me do the test and then I'll explain how it works. Same thing, I'm gonna milk all the fluid that's down so it's in the middle. Then I'm going to take my finger and I'm gonna push down on the patella and then rapidly remove it. What I'm looking for is swelling in the knee joint. So let's go back to that bathtub. If I have just a ½ an inch of water on the bottom of the bathtub, so the rubber ducky is just sitting on the top, that would be a little bit of swelling that's in the tub, a little bit of swelling that's in the knee. When I push down on the rubber ducky in the tub, I might see some ripples going out. But there's no way I can push it underwater that when I release my finger, the rubber ducky is coming racing to the top. So same thing here. If he has minimal swelling, when I push down, I might see a wave that goes off from the patella. That would be for minor. Back to my bathtub. If it's filled all the way to the top with fluid, I put my finger on the rubber ducky. When I push down, there's gonna be ripples, but when I let my finger go, it's gonna jump through the top of the surface. It's gonna be the same thing for the volatile patella. I push down, ripples, I let go, it'll raise back up. So that would be for major joint effusion. I just tell people that doesn't give you enough information. Just do the sweep test. So then you would know for certain the viscosity of the fluid, because you can't find it when you're pushing down.